Hello, ladies and gentlemen. I'm Professor Samir Jaber. I'm very happy here for this session. I want first of all to thank the Comen support. Thank you very much for all of you. We're happy to co-chair this session with my colleagues and friends. All of them will introduce themselves.
Good afternoon, our distinguished colleagues and friends. Welcome to the Comen Symposium Euro-China session on intensive care medicine. My name is Comen, and it's my great honor to co-moderator alongside the Samir Jaber. Okay. And we are very delighted to have with us today leading experts from both Europe and China who will share cutting-edge insights and advancements in the fields of intensive care. To begin with, let's warm welcome to Professor Dou Chang and Tabu to have the opening speech. Dou Chang, please.
Okay, everyone, good afternoon. Welcome to the Euro-China session on intensive care medicine, Comen Symposium. I'm Dou Chang from Shanghai, China. Firstly, let me introduce the history of the Euro-China joint session. As early as 2019, at that time, the president of ESICM is Joseph, and he discussed with me about holding the Euro-China Forum for Critical Care Medicine in China. After the multiple rounds of the coordination and discussing, at last, it was decided to hold the first Euro-China Forum for Critical Care Medicine in Shanghai in August 2020. Unfortunately, in the early 2020, there was an outbreak of the pandemic of COVID-19 in China. And soon after, the pandemic also outbreak in Europe. Until 2023, with the efforts of the Professor Tabu, it's a good contribution for the Euro-China. And at that time, the president of the ESICM, Adi Azoli, decided to hold the Euro-China joint session at the annual Congress of the ESICM, firstly in 2023. Then the first Euro-China Forum for Critical Care Medicine was held in Chengdu. It's a hometown of the Yankang in 2024. The second Euro-China Forum was held in Changsha this year, achieved a complete success. The Euro-China joint session was also held 3 times at the annual Congress of the ESICM. We hope that the cooperation between ESICM and the CSCM can continue to develop, and I wish this Euro-China joint session completely successful. Thank you very much. Also thank the sponsor, Comen, a famous Chinese medical company. I delivered the microphone to Professor Tabu.
Thank you very much. Good afternoon, everyone. So Professor Chen said a lot of things about our collaboration. So just to summarize, you know that we have this Euro-China Forum session in China, but also in the ESICM Congress for some years, and we started in 2023, as said by Professor Chen. And we are very happy for this collaboration, and we hope to continue in 2026 about this collaboration. And this is our pleasure because we learn a lot from the Chinese researchers, scientists, and intensivists, and I hope that also the Chinese scientists, researchers, and intensivists learn from us. So this is just sharing experience, sharing knowledge, and it is very, very, very interesting. And it is impressive when we go to China, to the National Congress, which was in Changsha last year, which would be in Xi'an next year. This is very impressive how many people attend this Congress. Around 15,000, around 15,000 attendees. So it is unbelievable, and it is important what to share and what to know from you. Thank you very much, Professor Chen, for this opportunity to collaborate in scientific congresses like this one. Thank you very much.
Thank you, Jean-Louis. Thank you, Professor Chen. Thank you for this introduction. It's my great pleasure to introduce the first speaker, my colleague and my friend, Professor Jilali Annan, who will speak about the nanocorticosteroid for sepsis. Thank you, Jilali.
Thank you, dear presidents, dear session chairs, dear colleagues, good afternoon. So my task is indeed in 10 minutes or so. If I could start with my slides. To briefly discuss about the nanocorticosteroids in sepsis. You have here my conflict of interest. And so the issue and the challenges, because glucocorticoid receptor is present in all cells, is that when you give IV corticosteroids to patients, you get a broad effect. So you, of course, target the cells you want to target, but you also have unwanted effects related to the fact that corticosteroids are distributed everywhere. So in an attempt to design precision medicine for corticotherapy in sepsis, we developed a nanocorticosteroids. So as you may know, there are 3 different types of nanoparticles. The polymeric, I don't have time to describe all of them, but the main issue with the polymeric particles is the possibility of aggregation and toxicity. And with the inorganic, like gold nanoparticle, again, you have issues with toxicity, issues with solubility limitation, and it's not very practical in practice. So we focused on lipid-based nanoparticles. Even so, the main challenge with the lipid-based is the risk of low encapsulation of the drug. So then we also leverage on the polyethylene glycol ethylation process to improve the nanoparticle physicochemical characteristics, helping, for example, increasing the hydrophilicity, increasing the molecular weight, and also decreasing the immunogenicity and antigenicity. This is the process that we develop in the lab to produce the nanocorticosteroids, when we started with dexamethasone palmitate. So here, very briefly, the slide is showing that the nanoparticle of dexamethasone that we did produce are of very high quality in terms of zeta potential and capability of diffusion in terms of encapsulation efficiency of dexamethasone, for example. Also in terms of stability, and if panel B is showing the spectral analysis, in green you have 3 dexamethasone, and in blue and red 2 types of nanoparticles of dexamethasone. One can see that the many spikes in the spectral analysis you can see in the green curve with 3 dex, all have disappeared with the nanoparticle of dexamethasone. Then in panel C, you have the size that we achieved, and in panel D and E, you have a high stability of nanoparticle dexamethasone, regardless the properties we were looking at. A major challenge, because you can tell me, okay, Guy, but you know, you can inhale corticosteroids. Okay, you can deliver them by nebulization. The issue is that the airways and the upper airways are extremely rich in glucocorticoid receptor, and so all the corticoid you will be given by inhalation or nebulization will be captured in the upper airway, and you won't be able to reach the deep lung. And this is why the nanoparticle is very important, because it will help targeting the deep lung. That is what we want in ARDS and in patients with sepsis. So we started with the small animal model using both the LPS challenge mice and the CLP procedures. We developed a specific device to nebulize the nanodexamethasone particle, and also we compared it to free dexamethasone given endotracheally or to free dexamethasone given IV. First, not going because of time, of course. I'm not going to describe all the slides, but I have highlighted the main message there. So dexamethasone nanoparticles given by nebulization achieved the same efficacy that free dex given IV or given intratrachely in terms of survival, panel A and B, in terms of organ function, panel C for liver and kidney, as well as in terms of cytokines production in the bottom panel. Then we looked at how the active drug is distributed, both in the lung and in blood. So dexamethasone, free dexamethasone appear as triangles. The nano particle dexamethasone is in square. So one can see that the concentration in panel A of dexamethasone in the epithelium lining fluid is very much higher in nanodex than in free dexamethasone. Looking at concentrations in the lung in panel B, so one can see how much higher was the concentration in the lung of a nanodex compared to free dex, and by contrast, in the blood, the concentration of nanodex were very low compared to IV dex, of course, highlighting that we indeed delivered the active drug exactly in the lung and not systematically. This is a very important demonstration of the efficiency to deliver dexamethasone to the deep lung. Then, also, it is important to look at where in the lung the drug is going. And here we highlighted that nanodex is definitely going into targeting. We will see neutrophils and alveolar macrophages. And as a result, in panel D, one can see that as compared to free dex, nanodex has a limited change and induce limited change in terms of blood glucose levels, sodium or cholesterol, and also has no effect on blood pressure because the drug is actively acting in the lung and only in the lung. Then we looked at the cells that are targeted, and again, to make the story short, definitively nanodex delivered active dexamethasone in interstitial macrophages and neutrophils, as shown in panel C and panel D and B, and as a result, achieved a nice modulation of the release in the lung of the various pro and anti-inflammatory mediators. Then we looked whether the dexamethasone that reached these cells has indeed effects on the proliferation of the cells and the function of the cells. So we investigated a number of parameters, nicely showing that the nanodex is preserving the number of macrophages, modulating their gene expression, and the release of inflammatory mediators, mainly by activation of the GR receptor. And this is true also regardless the type, again, to make the story short, the type of molecules signalization we were looking at. Likewise, we were able to nicely show that dexamethasone modifying the inflammatory macrophages in terms of proliferation, but preserving their phagocytic capacity, which is an important function in particular for the resolution of inflammation in the lung. Regarding the neutrophil as a target, again, the nanodex was able to reduce the recruitment of neutrophils from the blood. So very interesting, the drug delivered inside the alveolar is able to block neutrophils coming from the blood by acting at the different steps of the migration of the cells. So I'm finalizing my presentation here, showing that we could replicate everything by the CLP model. Everything's observed with the endotoxin models. We have mimicked in the CLP model The next step for us now is to move on to non-human primate before going to first administration in human. And also we have been very successful in developing nano-hydrocortisone and nano-fructocortisone. So as a summary, endotracheal administration of nanodexamethasone achieve comparable effects as IV dex on survival, organ function, and systemic cytokine production. The concentrations in the lung are very high, very low in the blood, and without peak concentration, preventing side effects. Reduce pulmonary inflammation, targeting primarily the neutrophils and the macrophages. Modulate gene expression and inflammatory mediator release by GR activation, and reduce inflammatory macrophages without affecting their function in terms of phagocytic capacity, and also reduce the recruitment of neutrophils, control their activation in the lung. Thank you very much for your attention.
Thank you very much, Gilali. We will move on to the next speaker, or we have question time, I think. Maybe at the end?
No, we have no time for questions. Maybe one question now. I don't know if we... you show some data about, finally, the lungs, by definition. But do you think that it is the same effects in septic ARDS or non-septic ARDS?
Yeah, but I think basically that regardless of the type of ARDS or acute lung injury, you will have the effects on the cells that are targeted are likely the same. Yeah.
Thank you.
Okay.
Please, yes.
Very exciting result, but you know, dexamethasone is a very strong steroid, is a very strong immunoinhibitor. So as you show, this nano particle could improve the inflammation, could inhibit the neutrophil recruit. But for the most ARDS, pulmonary induced ARDS, do you think this could prolong the viral or bacteria-induced the activity? And do you think the indication for this drug for what kind of ARDS, what kind of pneumonia could be used, and what time? Thank you.
Yeah, so I think the idea of precision medicine is to be able to deliver a drug, corticosteroids, to the cell or the tissue you want to target. So the issue is modulating lung inflammation without affecting the rest of the body. That is the main action. Of course, because we are reducing neutrophils activation and recruitment in any pathogens-related lung infection for which neutrophils are important, like flu, for example, you should be very cautious because you will likely reduce the capability of lung cells to clear the influenza virus. For other viruses not dependent on neutrophils response, it might be different.
Thank you very much, Gilali. Again, bravo, comme on said. We will move on with Giacomo Bellani from Italy, transition from spontaneous breathing to totally assisted breathing. Thank you, Giacomo.
Thank you so much for the invitation. Also last year I was in Shanghai, and thanks for the invitation this year in Xi'an. It's a great privilege for me to be able and participate in this joint venture between ESICM and our colleagues from China. We're shifting the gears a little bit from the beautiful presentation of Dr. Anand to go back to something a little bit more traditional, if I may say so, in terms of pressures and volumes and all the stuff like that. So my conflicts of interest that are not really specific for the present talk. And if we consider the trajectory of a patient who is admitted to our ICUs, we might start off with a phase of non-invasive ventilation, and then we know that unfortunately unfortunately, some patients fail and require invasive mechanical ventilation, normally with a controlled phase. And then in different ways, we switch the patients to assisted ventilation and progressively reduce the assistance that they receive from the ventilator. And finally, hopefully, we achieve a separation from the ventilator. And if we take a look at what the literature has published, what the literature is focused on, we see a great deal of attention for the phases of non-invasive ventilation, a great deal of attention for the intubation phase, a lot of research done on the early phase on controlled mechanical ventilation, lung protective strategy, prone positioning, ECMO, you name it. And then we get to the point where the patient is eligible for separation from the ventilator with or without success. I have to say that all that happens in between is a relatively gray zone in terms of what we know, but can be a relatively large phase of the patient stay in the ICU. So we and others have been working on how to predict the success of the switch from controlled to assisted ventilation and how to increase the chances that this will be successful. This transition is delicate, and if patients fail the first switch to assisted ventilation from controlled one, we and others have shown that this is independently associated with an increased risk of death. This is COVID patients, and as you see, patients who succeeded the switch to assisted ventilation had a much favorable outcome as compared to those who failed. Clearly, this is observational data, so there's always the possibility of some confounders, although I have to say that we have normalized for as many parameters as possible. And quite interestingly, around the same period, this paper from Argentina, Dr. Perez, was published, and in two different cohorts of patients with COVID and with ERDS from other causes, they found more or less the same findings as we did, in that the switch from controlled to assisted ventilation was independently associated with an increased risk of death. I don't have the time to show you here, but what was quite interesting was that also we and them found more or less the same predictors for this switch. And essentially, to make a long story short, one of the parameters we should really be focused upon to succeed in our switch is to avoid the under and the over assistance to our patients. Both are associated with potential detrimental side effects, such as patient self-inflicted lung injury, myotrauma, left ventricular failure for the under assistance, but also the over assistance leads to asynchronies, unnecessarily high tidal volume, diaphragmatic atrophy, and the need for higher sedation. So to succeed in switching the patients to assisted ventilation, there are, of course, many aspects we need to take into account: sedation, fluid balance, hemodynamics, control of infection, many ingredients. But one of them is try and stay in the sweet spot of the that avoids both over and under assistance. In this paper by Mattia Docci as a first author, we have shown that when we decrease, this was pressure support ventilation, but it would work also for other types of assistance. When we decrease the level of assistance that we provide with the ventilator, the peak inspiratory pressure decreases because this is what the ventilator is doing, but the patient with the gray bar comes in replacing the pressure we have removed from the ventilator and keeping the tidal volume stable, meaning that we may modulate the effort and the tidal volume of the patient only to a given extent. And this is what makes assisted ventilation much more tricky than controlled mechanical ventilation. And also, as a consequence, as you see the red bar, the driving pressure remains more or less stable, irrespective of the support which we give. A lot of emphasis was put over the last year on the use of esophageal pressure at the bedside to measure the effort of the patient, but I shall say that nowadays we have at least two methods that allow to measure the global pressure distending the respiratory system and the effort of the patient that are based on inspiratory and expiratory hold. So you just have to push the inspiratory and expiratory hold button. And again, long story, very short, we have a method proposed by Giuseppe Foti many years ago in Italy, and then which we have reappraised, that it's basically pushing an inspiratory hold maneuver and measuring the global driving pressure. And we have another method proposed by the Canadians that relies on an expiratory hold. I don't get into the technical details, but we just published this paper that will come out on the Blue Journal soon, showing that the values of driving pressure that we compute with the proposed techniques are tightly associated with the outcome of the patients. Again, this is just an association study. It does not necessarily prove a causal effect of the driving pressure, but suggests that even during assisted ventilation, driving pressure could be a target for a lung protective ventilation, provided we measure it properly, as I showed you. And as a last result, I also would like to show you to ask you to focus on this upper right panel, which shows the trend over time of the driving pressure in patients who will die or will survive. And as you can see, they start off a little not that different. For non-survivors, it's already a little bit higher, the pressure. But then what happens is that the injury perpetuated by the patient efforts leads to a worsening of the driving pressure, probably causing the negative outcome of these patients. So, in summary, I think that we, as both, let's say, clinicians, but also researchers, should focus a little bit more and pay a little bit more attention to this transition phase. Esophageal pressure is certainly a standard, but it has also become, I would say, a nice to have in intubated patients, because we have excellent and free tools to monitor the effort and the driving pressure, such as the inspiratory and the expiratory hold. And with this sculpture from our land, I thank you very much for your attention.
Thank you very much, Giacomo. We have time for one or two short questions, maybe. Just one word about sedation, Giacomo, no?
Yeah. No. Yeah, as I said, of course, there are so many components of the switch, and sedation is clearly one of these, because if we start to decrease sedation when we want to switch the patient to assisted ventilation, is already too late, right? We should have every day like sedation breaks, neuromuscular agents breaks. And then sedation, it's unfortunate because we would like to have the patient a little bit awake, but it's also the only way that, almost the only way that you have to manage the drive. So it's little, sometimes it's really a very narrow pathway.
I like what you said, Giacomo. When you stop sedation, it's too late. Really, it's very nice sentence. I like it.
I mean, sometimes it's good to have sedation. Don't get me wrong. In the ICU, I have the honor to direct. We keep the patient deeply sedated. But the point is, if you say, okay, I want to switch this patient to assisted ventilation, and at that point you start decreasing sedation, then it's too late. This is what I meant.
We have one question. Thank you.
Yeah, okay. The question is how to balance the lung protector ventilation and the diaphragm protector ventilation. Just as you showed, when you increase the PS level, the delta driving pressure higher.
Yes.
But PMI lower.
Yeah.
Yeah, how to balance this?
I think in this way, we do not have actually two competing needs, in that if we are able to get a sweet spot of a reasonable amount of breathing, this is both beneficial for the diaphragm and for the lung. But if the work of breathing is either too low or too high, it's injurious both for the diaphragm and for the lungs. This is my short answer, because I know I don't have much time, but I could talk hours about this. Thank you so much.
Oh, Professor.
Okay. Thank you, Professor Benani, for your valuable insights. And now, let's continue with another critical topic in respiratory care. I'm pleased to invite Professor Ling Liu from Nanjing, China, and who will present an EIT guided people setting in ARDS improves outcomes. Professor Liu, please begin.
Yeah, hello everyone. I'm Ling Liu from Zhongda Hospital, Southeast University, China. And it's my great honor to be here to present our recent research on behalf of the Chinese ARDS Research Network. And we focus on the EIT-guided PEEP setting in ARDS, whether it improves outcome or not. I have nothing to declare. And as we all know, when we setting PEEP, we always balance between the overextension and the lung collapse. And there are many methods to titrate PEEP. The most common use was the ARDS-9 PEEP FiO2 table. However, the EIT cross-point method balance minimize the overextension and collapse. It has been demonstrated that by a meta-analysis, which enrolled 13 studies, that EIT-guided PEEP improved the respiratory compliance. However, the impact of EIT-guided PEEP on clinical outcome has not yet been proven. A recent phase 2 randomized control trial include COVID-19 related ARDS patients showed a faster improvement in the modifier of the lung injury score compared to the PEEP FiO2 table. But what is the effect of EIT-guided PEEP on mortality is still not known. So based on the favorable physiological effects of EIT-guided PEEP, we hypothesize that EIT-guided PEEP will reduce mortality of patients with moderate to severe ARDS compared to the classical lower PEEP FiO2 table. So we did a prospective multiple center randomized control trial. This trial was conducted in 5 ICUs in China, and we measured the recruitment inflation ratio, that means R ratio, to measure if the patient is high recruitability or low. And the patients were randomized to 2 groups, EIT-guided PEEP group and the ARDS net strategy. That means we use low PEEP FiO2 table. And the ventilator parameters in both groups was comparable. And during the EIT-guided PEEP group, we did PEEP titration from 20 to 0. PEEP was titrated daily, and if the patient was prone, we retitrated the PEEP. And in the control group, we used a lower PEEP effective table. The primary outcome was 28-day mortality. And we calculated a sample size of 188 in each group. Also, we set interim analysis. Here's the flowchart. The trial was stopped earlier after the interim analysis by the DMC. They recommended that to stop the trial due to a low probability of the demonstrating a clinical benefit of EIT-guided PEEP. Totally, we include 93 patients in the primary analysis in EIT group, and in the control group, the patients was 97. All the baseline parameters were comparable between groups. In the overall patients, PEEP was comparable in both groups, no difference. And in overall population, the driving pressure, respiratory system compliance, and PF ratio between two groups within 7 days was all comparable, no difference. And for the primary outcome, the 28-day mortality was comparable between groups. Here shows a crossover of the Kaplan-Meier curves of the two groups. For the secondary outcome, the ventilator-free day, ICU length of stay, hospital length of stay, and so on, were comparable between groups. And the proposition was performed in more than 70% of patients in both groups. For the predefined subgroup analysis, we found that the 28-day mortality of patients were higher in higher recruitability patients was lower in the EIT-guided PEEP group when compared to the low PEEP F2 table group. To clarify why the EIT-guided PEEP reduced the mortality in high recruitability ARDS patients, we did more analysis. And we can find that the PEEP levels in the EIT-guided PEEP group was higher than control group during the first 3 days. Also, we found that the driving pressure in EIT group was lower than control group during the first 5 days. And also, the respiratory compliance in the EIT group was higher than the control group during the first 3 days. Our recent article also confirmed that EIT-guided PEEP improved V2 matching only in high recruitability ARDS patients. However, we have some potential explanation of the negative results. Very similar lung protective ventilation settings were applied in both study groups. And the PEEP during the first week was comparable between the two groups. So no difference of PEEP, no difference of mortality. And the high proportion of patients positioned in prone in both groups may have diluted the advantage of EIT-guided PEEP. And the short duration of intervention, we only titrated PEEP in the first 7 days might be a reason. And we enrolled a heterogeneous population of ARDS patients, not only focus on the high recruitability and some kinds of ARDS patients. So that's the reason why we get negative results. We have some limitations in this trial. First, the trial was stopped earlier, and it's unable to be landed. And the daily decremental PEEP trial from 20 to 0 may lead to long day recruitment. And we repeat the recruitment maneuver, maybe carry the long over distension. And most of our patients, I think about 40% of patients are COVID-19 related ARDS and pneumonia. And also that the intervention duration is only 7 days, and some reviewers said that might be too short. But I think during ARDS, in ARDS patients, in the first 7 days, the patient has a result to switch to assist ventilation or died. So I don't think it's too short. In conclusion, EIT PEEP strategy demonstrated comparable feasibility and safety to the low PEEP-FO2 table strategy, but did not significantly reduce 20-day mortality in these heterogeneous patients of moderate to severe ARDS, and its application in patients with higher recruitability decreased the mortality and appears more promising. And the result should be interpreted with caution. And early termination may have limited the study power to detect the clinically important difference. And after that, I think we should focus only on the patients with high recruitability to using the EIT titrated PEEP. Thank you for your attention.
Thanks. Thank you, Professor Liu, for your valuable lecture. Any question? Please.
Okay, I have one question for Dr. Liu Lin. So I noticed that the PEEP titration only once. So if you redesign the research, what do you think the PEEP titration frequency for patient?
The PEEP was titrated once per day, and if the patient was the position of the patient changed, we retitrated the PEEP.
Okay, thanks.
So it's not only once; it's once per day.
Okay, thanks.
Okay, thank you for a very excellent talk about the EIT guided the PEEP set. As you know, there are several tools to set the optimal PEP, and maybe different kind of the ARDS use the different tool. And for the EIT guided PEP setting, what's the advantage? Also, what's its disadvantage? Thank you.
Yeah, thank you, Professor Chen. And I think it's a good question because we don't know what the optimal method to setting PEEP. And we use EIT PEEP, titrated PEEP. That means we did a PEEP decremental measurement, and we just found with the PEEP decrease and the or distension decrease and the collapse increase. So the cross-point PEEP, that means we have the maximum or distension plus collapse. But even that, we don't know. Is or distension more harmful or the collapse? So we just use this method to get a PEEP, we think maybe with the minimum over distension and collapse.
The gentleman? Oh, ladies first.
Yeah, thank you. Fredericks from Kiel in Germany. Congratulations on your study. I'm very happy that you conducted it. I also would say that the decremental PEEP trial to 0 is maybe not so good. Can you think of any other interventions that could be analyzed by EIT that are not so aggressive that could be applied in your patients?
Yeah, thank you for the question. I think it's a major limitation of our trial. And in most publications with a decremental PEEP, they from 20 to 6 to 4, something like that. And we decreased the PEEP from 20 to 0. I think maybe caused the decremental of the alveolar. But after that, we did a recruitment maneuver, then set the cross-point PEEP. So I don't think it's a big problem because we have a lot of COVID-19 patients with very very hard lung. So sometimes we titrated the PEEP, maybe just a 4 or even less. Thank you.
Yeah, thank you very much.
Do we have time? Sure. So now, congratulations, super interesting. The fact that one has to use recruitment to inflation ratio and then EIT, it adds a layer of complexity. So since EIT also evaluates recruitability, I was wondering whether maybe one could use EIT to assess recruitability as opposed to recruitment to inflation ratio, and if you have looked at this in your data. Thank you.
Yes, thank you for the suggestion. That's because we have a control group. We don't use EIT in that group. And we need to know the recruitability in all the patients, so we choose a easier measurement of a single breath measurement of the eye ratio. Thank you.
Thank you very much again. Bravo. Nice. We will move on with the next speaker, my friend, Professor Giuseppe Citerio from Italy, about the research between Europe and China. Thank you, Giuseppe.
Thank you very much. Thank you for the invitation. I change a little bit the topic because I would like to discuss about collaboration, not only to a single study, because I think we have a common problem. We have a lot of severe brain damage with high mortality and disability, and we don't have any possibility to have a definitive cure. And we study a lot in the last few years, but we face a lot of problems: biological heterogeneity, research fragmented, failure randomized controlled trial, and we need to build up a better collaboration, because we start to know that TBI is not a single disease, traumatic brain injury, but is a syndrome, very heterogeneous. And we started to understand that we are able to classify the patient looking at biomarker, looking at other parameters during the course of the disease inside the ICU. These are data from Center TBI, a very large European collaboration, in which we were able to define some phenotype of the disease. Each of them was connected with a different mortality. And so today we have a disease that we are able to better categorize, to better phenotype, but we don't have a treatment personalized for each of these phenotype. And we fail a lot because we have an idea of looking at brain damage like an evolving disease and putting under the umbrella of traumatic brain injury all these elements. We try a lot of trial and we fail a lot. And so I was thinking why we need to have a good collaboration, because we have the same problem and we can have complementary expertise, as we saw now in the next few slides. We have a large patient data set in your country, in China, and we can use multidisciplinary collaboration. And thinking about synergy, I will touch these 4 points. The first one is share research, because I think we have a similar problem in China and in Europe, and I use 3 examples for discussing how can we solve the problem. I'm a neuro guy and I study a lot of ICP, and for talking about ICP, we don't have clear indication of a use of ICP, a threshold, and if we are using a device, an ICP catheter that is useful. And we study in a large collaboration study that has been endorsed by the European Society, the Synapsis study, 2,000 patients, more than 2,000 patients. And we published a study on the Lancet, and we were able to understand that in more severe cases, there was a benefit having an ICP device. What we did, we started a collaboration with a Chinese group in Beijing, and we applied the same protocol, the same Synapsis ICU protocol translated in Chinese. We provide the ACRF, and the group led by Gui Gao did the same work we did in Europe, 2,500 patients enrolled in China. The paper is now submitted to a big journal, and we are looking to see the effect of measuring and treating ICP, and the Chinese court have the same similar result compared to the European court. This was an example. Another example in the ventilatory field was the VentiBrain study, in which we published on intensive care, we wanted to understand the variation of ventilation practice across TBI and stroke, ischemic and hemorrhagic stroke. We saw a lot of ventilator practice differently between countries, but mainly we saw the lung protective strategy has been applied to neuro patients in this setting. But looking at China here, I like China in this caterpillar plot. And as you can see, for example, China is using tidal volume higher than other country, and the ventilatory rate is a little bit lower. So we can understand that China is different from Europe in the setting of a ventilator. And at the end of the day, putting together Chinese and European data, we saw that the protective ventilation is feasible in TBI patients, and there are some elements that are associated with higher mortality. For example, low PEEP or high PEEP and the higher driving pressure. But looking at Synapse ICU, China 31 centers provide the biggest contribution to the study. Another example of collaboration, we are using this drug, diclofenac sodium, in our unit since 1994, and we did a very small randomized study. The Chinese colleague looking at this paper decided to do the same, and is ongoing a trial with 1,000 patients on the same topic, trying to understand if this strategy that we apply every day is able to succeed in controlling fever in the traumatic brain injury patient. Another example is to use reparative strategy, because we switch our way of thinking, because we did a lot of neuroprotection and we failed to do neuroprotection in the past, and we start to think about reparation of the brain after trauma. And we did with Elisa Zania 10 years of experimental in the lab, in which we saw the protective effect of the using of mesenchymal stromal cell. And we started in Europe, mainly in Italy, this trial, the matrix study, testing the efficacy and the biological effect of injection of mesenchymal stromal cell in traumatic brain injury in the early phase. We did the same we are doing the same in China. I visit a big company producing cell, and we are starting the same approach on Chinese patients. And the last point comes the other way around, because we learned from Chinese colleagues that neurostimulation is a possibility, and the group in Beijing was publishing in intensive care. This study has been discussed a lot because the results are striking, right median nerve stimulation in China, and we start thinking using neurostimulation for promoting recovery in the patient. But we did the other way around, because we wanted to start stimulating the vagal nerve through the ear, and we are starting now a trial applying the same concept that has been used in China for promoting recovery of consciousness, because promoting the way that goes from the brainstem to the thalamus and to the cortex, we probably will be able to reduce the length of disorder of consciousness in very severe patients. The last point I want to touch is education, because we have some program in Europe, and last year we have many Chinese colleagues that did join us, and we are doing the same in the other way around, because we are discussing with a Chinese colleague the possibility to build up some experience on neuropatient, on neurocritical care, a common pathway for teaching to the Chinese colleague together the neurocritical care, and using also information from China to bring to Europe. This is my last slide, and I think that we touch a lot of possibility of collaboration, and I think the experience we have with Chinese colleagues is very good, because we develop a lot of trial, a lot of protocol, and we were able to succeed in doing things together. And I think it's the way to go for the future. Thank you very much for your attention.
Thank you very much. Due to the delay, we don't have time to make some questions, Giuseppe, sorry. We should move on to the next speaker.
Okay, let's move to the final presentation. It's my pleasure to introduce Professor Yun Nong from Beijing, China, who will present the Peking Union Medical College Hospital and the AI algorithm model achieved in practical application with Comen machines. Professor Nong, please.
Thanks. Thanks for the invitation. You can see the, My topic is some experience of the cooperation with the Comen machine. I think this for me it's a new topic. So this is interest to no conflict interest to declare. So this is our hospital. Is one of the famous hospital in China, and the cooperation is around the development of a trend, but included the multi-device integrate, multi-platform access, and the cross-department and the remote transmissions, and just like that. So I talk about the remote network platform for ICU mechanical ventilation. I think this is a quite easy topic for to discussion. So we now we can acquire the different department, the dynamic mechanical ventilation data. We accrue the data and make the cloudy decision making and back to the clinical use. So this is the key features. So that is central monitoring and bi-directional control and management of patient and data management. So we around the monitoring the ventilator waveform to management of the data, remote monitoring, and event analysis and data report. So this is our present work. We produce the website. You can use your computer or use the mobile phone. You can gather the waveform, and we produce some wearable device like the watch. You can see this can monitor and dynamics the ventilator waveform. So why you should monitor the waveform? We want to review the patient's situation and summarize and analysis. So this is multi-devices across units and remote monitoring and platform. I think that is Comen's plan. That is our plan. So first we focus on the asynchrony. So for the ICU doctor is very deficient, especially for the rural place or the western place. So we need the remote to control or remote to monitor the ventilator status. So we management asynchrony. The synchrony include from the cycle and the trigger and the escalation. So this is examples we the AI automated analysis of patient ventilator asynchrony. Is this? Can I use the laser? You can see in the left upper, okay, it's like this. This is the raw data. You can see the different waveform, different asynchrony. And at the beginning, we should to give the criteria to normalization the different the asynchrony, and we can get the size, the time, the amount, and the volume to get the adaptive average pool. Then we can get the separable convey block. After that, you can get the label, so gradization. This is for the double trigger. This is for the effective effort. That's just will get the annotation, the platform. So use this, the mode, we can get the 6 or 8 asynchrony modes. So we can use synchrony, use them with the platform, just as delayed cycling, reverse triggering. So, and after that, we do some search around this the platform. First, we survey the recognition rate of the ventilator waveform. As we know, actually, for the ICU doctors, deficiency of the respiratory mechanisms, I think so. So they need more training in ventilator to conducting the critical respiratory clinical research. So increase the ability to identify the patient ventilator synchrony. And the remote ventilator view platform assists to identify the patient ventilator synchrony. After that, we can see the cloud platform enables continuous monitoring the mechanical ventilation, and we can get some interview from the internist. That is, see, we can specificity that identifies insufficient flow, premature cycling, and delay in the cycling. And like that, 6.2% of interview interviewers support the application of this platform. And we do some clinical use for dynamic monitoring the very severe ARDS patient, like the COVID-19. We use the automatic calling to recognize the 8 PVA subtypes and calculate the overall synchronous index. So as we can see the result, the AI more than 10% more likely have a fewer 28-day ventilator-free days. And amongst the 8 types of PVA, the flow insufficiency was be found to associated with the prognosis. And we do more research around that. We recruit 215 patients from 4 Chinese tertiary hospitals, and we found if the mean airway pressure more than 10 was recruited, and 6 types PVA was interested. So the total asynchrony index was correlated with the PVA ratio and the respiratory rate, and the asynchrony index, and especially for flow starvation index, was negatively correlated with the ventilator-free days at day 28. This is our study. And finally, I reported the report for the mechanical ventilation. At the beginning, I do this work, I think it's something strange. But as you know, some rural place, some far from the big city, is very deficient as the nurse and the RT. So it makes sense. So the report remote including the ventilator modes and protective ventilation strategies implement and the PVA. So why we need the 24 hours remote report? So actually, the people intensivists still there to measure the plateau pressure just once a day or twice a day. So if you have 24 hours, we can dynamic monitor what happens the ventilation. So this is the first our study around 24 hours of mechanical power that is associated with mortality for clinical patients. So we produce dynamic mechanical power, and that is associated with patient's outcome. This is our research work, the mechanical, how to use the mechanical power to measure dynamic mechanical power to measure. That is the calculation use the mean airway pressure to replace plateau pressure to monitor the dynamic measures. So we use this method to implement remote network platform for ICU mechanical ventilation. We do the quality control around the POMC medical islands, around 8 or 10 hospitals, a lot of patients involved in. Okay, thank you.
Thank you, Professor Nong, for showcasing such innovative application of AI in intensive care. Any question? And I'll open the floor discussing.
I think we should stop because the time is finished. But I propose to everyone, first of all, I want to call all the speakers here for the photography. And please. And waiting coming from, I want to thank all the speakers for the nice presentation, for the nice quality. It was a real pleasure. I learned a lot with all of you.